Hello and welcome to the topic Paraproteinaemias in the Haematology module. By the end of this topic, you should be able to define paraproteinaemias, explain the pathophysiology and outline the causes of paraproteinaemias, outline the investigations to ascertain the diagnosis and differential diagnosis, and finally discuss the management approach. Let's get started. First, let's look at the term paraproteinaemias, also known as monoclonal gammopathies. In this deck, we will be using them interchangeably. The prefix para here refers to being abnormal, hence abnormal proteins. Paraproteinemia represents a spectrum of related diseases and it's characterized by monoclonal proteins or paraproteins in the serum or urine. These abnormal proteins can be found in the form of intact or fragments of immunoglobulins or even free light chains. Paraproteinemia is often accompanied by monoclonal plasma cells in the bone marrow, sometimes in soft tissues and peripheral circulation. Monoclonal gammopathy of undetermined significance or MGUS is the most common monoclonal gammopathy found in 1-2% of adults. The transformation rate from MGUS into multiple myeloma is roughly 1% per year. Before moving on to the pathophysiology, let's first have a look at the physiological scenario. Plasma cells are effector cells of the B cell lineage. They function to secrete antigen-specific immunoglobulins which mediate the humoral arm of the immune response. A normal or intact immunoglobulin has two identical light and heavy chains. There are 5 major classes of heavy chains which correspond to the 5 classes of immunoglobulins, which are gamma IgG, alpha IgA, mu IgM, delta IgD, and epsilon IgE. Kappa and lambda are the only 2 variants of light chains. Now back to the pathophysiology of paraproteinemias. What paves the way for development of paraproteinemia is the clonal mutation of plasma cells. Clonal expansion of plasma cells result in the production of monoclonal proteins which are either immunologically homogeneous immunoglobulins or fragments of them, both of which are abnormal. The cause of this clonal proliferation ranges from asymptomatic clonal expansion to an underlying lymphoid malignancy. A potentially life-threatening complication of paraproteinemia is the development of primary amyloidosis. Associated conditions include or spectrum of diseases related to paraproteinemia are listed in the next coming slide. Here are the spectrum of diseases related to paraproteinemias. We have the malignant component and the benign component. Under the malignant component, there is plasma cell diseases and B cell, usually IgM diseases. However, under the benign component, we have autoimmune or inflammatory diseases, infectious diseases, as well as post-transplant effect. While most patients with paraproteinemias remain asymptomatic, patients who have progressed to symptomatic myeloma or who have developed amyloidosis may present with weakness and fatigue which are attributed to anemia and hypercalcemia. Pains are most likely due to lytic bone lesions, vertebral compression fractures or cord compression. Confusion and altered mental status is likely due to hypercalcemia, hyperviscosity and uremia. Numbness and tingling are symptoms of peripheral neuropathy and cord compression or even hypercalcemia. Paraplegia or quadriplegic symptoms are generally attributed to spinal cord or vertebral compression. Visual symptoms, on the other hand, are a result of hyperviscosity. Recurrent infections are due to hypogammaglobulinemia. Polyuria, polydipsia, and constipation are caused by hypercalcemia. Increased bleeding and bruising are manifestations of thrombocytopenia, hyperviscosity, uremia, acquired clotting factor inhibition, and interference with the bleeding cascade. Increased bleeding and bruising are manifestations of thrombocytopenia, hyperviscosity, uremia, acquired clotting factor inhibition, and interference with the bleeding cascade by M proteins. Peripheral edema is suggestive of associated hypoalbuminemia, nephrotic syndrome, and renal failure. Loss of height and kyphosis is most likely due to vertebral compression fracture, while dysphagia, jaw claudication, diarrhea, and macroglossia indicates development of amyloidosis. A subset of patients present with life-threatening complications, though most happen in context of active symptomatic myeloma. This requires urgent therapy to control symptoms to avoid devastating consequences. Acute renal failure. Approximately 20% of patients with myeloma have renal failure at time of diagnosis. Other patients may also have compromised renal function. Most common cause of renal insufficiency is light chain cast nephropathy. Others include hypercalcemia, light chain deficit, light chain amyloidosis, hyperuricemia, contrast dye, cryoglobulinic vasculitis, and NSAIDs related. Patients with light chain cast nephropathy usually have elevated serum free light chain, which is more than 1 gram per liter. Next, hyperviscosity syndrome, and it's common in IgM monoclonal protein, and Waldenstrom microglobulinemia. Suggestive symptoms include headache, visual symptoms, typical fundoscopy appearance, change in mental status, and one needs to measure serum viscosity for this. Next would be compressive myelopathy, and this involves vertebral bodies, such as causing compression fractures. It is rare, but it can cause retropulsion of the fractured material posteriorly into the spinal canal, causing cord compression. The exact etiology of monoclonal gammopathy is unknown. However, there are several factors suggested that are thought to be linked to its development. First, genetics. Observations have shown increased prevalence of MGUS among Black population and among first-degree relatives. Secondly, environment. There is an increased prevalence of myeloma and MGUS among survivors of atomic bombs and those with significant exposure to radiation or chemicals such as pesticides and petroleum. Moreover, infectious agents have been linked to the development of paraproteinaemias, the genetic sequence of human herpes virus which have been identified in clonal plasma cells. Additionally, the association of monoclonal proteins with autoimmune conditions suggests that immune response may play a role in the development of monoclonal proteins. Specifically for MGUS, fluorescence in situ hybridization of FISH, gene expression profiling or GEP, and array comparative genomic hybridization techniques have demonstrated that monoclonal plasma cells in MGUS and myeloma have numerical and structural abnormalities in their chromosomes. These numerical abnormalities appear as increased copies of odd-numbered chromosomes referred to as hyperploid picture or complete loss of certain chromosomes such as chromosome 1, 13, 14, or 17. Structural abnormalities include translocation of immunoglobulin heavy chains as well as deletions in chromosomes. These are also possible causes of paraproteinaemias. Moving on to the investigations, there are multiple laboratory tests involved in identifying monoclonal proteins. Detection typically occurs when there is elevated total protein or elevated sedimentation rate, which leads to additional testing. Other times, patients present with signs and symptoms suggestive of monoclonal protein-associated conditions such as myeloma. Initial screening tests in any paraproteinaemias include serum protein electrophoresis and a 24-hour urine collection with immunofixation performed on both samples. A 24-hour urine examination may be replaced by serum-free light chain assay if there's the test available. Once the presence of monoclonal proteins are confirmed either in the serum or urine, subsequent tests will depend on the clinical scenario. Although statistically most patients will have MGUS, multiple myeloma and amyloidosis must be ruled out, and this requires quantification of the monoclonal proteins. M protein levels below 1.5 gram per deciliter and patients who are asymptomatic with no other lab abnormalities are likely to have MGUS. Evaluation of M protein levels should be repeated in 3 to 6 months to reassure. A bone marrow biopsy demonstrating clonal plasma cell exceeding 10% is the main criterion for diagnosing multiple myeloma. At least an additional myeloma-defining event is needed to make the diagnosis. We can remember these events with the mnemonic CRAB, C for calcium elevated exceeding 11 mg per deciliter, R for renal insufficiency where creatinine clearance is less than 40 mL per minute or serum creatinine exceeding 2 mg per deciliter, A for anemia in which hemoglobin is lower than 10 grams per deciliter, and lastly B for bone lesions seen as punched out lytic lesions and vertebral compression fractures on CT or MRI. If suspicious for amyloidosis, fat aspirate and bone marrow biopsy is recommended. All patients must have a full blood count, serum chemistry with serum creatinine, serum calcium corrected for albumin, bilirubin, ALP, liver enzymes, and urine analysis. Common findings aside from monoclonal proteins are anemia, thrombocytopenia, rouleau formation on peripheral blood smear, elevated ESR and CRP. Other investigations including elevated circulating clonal plasma cells, hypogammaglobulinemia, hypercalcemia, hyperuricemia, elevated creatinine and urea, elevated LDH, CRP, and elevated serum viscosity, as well as bone marrow plasmacytosis. Now, what are the common scenarios we get? So, MGUS warrants a serum protein electrophoresis with immunofixation. In a context of CLL, patients usually present with B symptoms, lymphadenopathy, and hepatosplenomegaly. FBC reveals elevated white blood cells and lymphocytosis. In a case of non-Hodgkin's lymphoma, the clinical presentation is similar to that of CLL. FBC, on the other hand, reveals pancytopenia. CT scans will illustrate enlarged lymph nodes and organ infiltration. Moving on to management, in the case of MGUS, there's no specific treatment. The rate of transformation is approximately 1% per year. Hence, monitoring M protein levels is essential to identify early progression to myeloma, Waldenstrom microglobulinemia, amyloidosis, or lymphoproliferative disorders. Patients are recommended to follow up with serum protein electrophoresis at 6 months, and if deemed stable, follow-up interval can be prolonged to even 2 to 3 years, or when symptoms suggestive of plasma cells malignancies arises. High-risk patients should follow up annually for life, and some studies have shown that patients may benefit from intravenous bisphosphonates for disease-associated bone loss, though the frequency and intensity of treatment is less than of patients with multiple myeloma. Lymphoma is treated with chemotherapy, specifically for lymphoplasmacytic lymphoma, that is Waldenstrom macroglobulinemia, presenting with hyperviscosity syndrome. Plasmapheresis is a safe and well-tolerated choice of initial treatment. Amyloidosis is controlled with steroids and may require patients to undergo chemotherapy. Now let's summarize. As defined, paraproteinemia, also known as monoclonal gammopathy, represents a variety of related diseases that are characterized by the presence of monoclonal proteins in the serum or the urine. Pathophysiology-wise, what sets the stage for the development of these abnormal monoclonal protein is the clonal expansion of a mutated plasma cell. Life-threatening causes range from acute renal failure to deep vein thrombosis. There's no exact cause that has been isolated. However, genetic, environmental, infectious, and autoimmune factors have been hypothesized. Associated conditions are lymphoproliferative diseases, infections that predispose or are associated with monoclonal gammopathy, and inflammatory or autoimmune conditions. First-line investigations in suspected cases of paraproteinemias are a serum protein electrophoresis and a 24-hour urine collection with immunofixation performed on both samples. A serum-free light chain assay may be used when screening for monoclonal protein, and this replaces the 24-hour urine collection with immunofixation. Management in most cases, that is MGUS, is a watch and wait approach. Cautious monitoring and follow-up is crucial to catch early disease transformation. Otherwise, management is tailored to its underlying cause. We have come to the end of this topic. Thank you for your time.